Respiratory Assessment by Breanne Leary.
First, let's talk about how to perform a comprehensive respiratory exam. This exam is going to be made up of 3 key parts: the look, listen, and feel model. Before we start, let's talk about a few basic terms that you'll need to be familiar with. The first is that of tachypnea, otherwise known as a fast breathing rate. Bradyapnea is the term we use to describe a low breathing rate. Apnea describes the patient is not breathing at all or has a respiratory rate of 0. Dyspnea, or respiratory distress, speaks to the patient's difficulty in their ability to breathe. The first step is to just take a look. You can always gain a great amount of information simply by looking at the general appearance of your patient. First, you want to ask yourself, how does this patient's breathing look? Do they look calm and comfortable? Are they in a position where they're trying to put themselves in order to breathe more easily? In an extubated patient that's ill, they'll often try to find a position of comfort, one in which they're able to breathe the easiest. For a baby with croup, that may be in their mother's arms where they're calm and comfortable. It is always best to leave an extubated patient in the most comfortable position for them, especially while you're performing your exam. You may see a patient tripoding or actually on their hands and knees, bent over, hunching, or you may notice that they're drooling a lot. Next, you want to look at their face. Do they look afraid? Are they having a hard time breathing? Do they look drowsy, lethargic? Are they not responding to you at all? Are they anxious, irritable, restless? All of these things can indicate that they are not effectively breathing. Next, you want to look at their overall skin color. Do they look pale? Are they mottled? Do you even notice some cyanosis or a bluish tint to their color? You may notice these things around their lips, which is known as circumoral cyanosis. You also may see that their hands or their feet appear a little bit blue. These things could indicate they're not getting enough oxygen. Next, you want to take a look at the child's trachea, which is located midline in their neck. You always want to assess and make sure that that trachea remains in the middle of the neck position. If the trachea has moved to either side, that could indicate that the patient is experiencing a pneumothorax. The next thing you want to assess for is the respiratory rate. This can be done simply by watching your patient breathe. What you want to do is count for a minimum of 30 seconds to see how many breaths the patient takes. It is very important to count for this long because infants and children often have some variation in their respiratory pattern, and if you don't count long enough, you may end up with an inaccurate respiratory rate. The normal rates for patients should be as follows. In newborns, you can expect the baby to breathe between 30 and 60 breaths a minute. For young children, it should be about 20 to 40 breaths per minute. In an older child, anything from 15 to 25 breaths per minute is acceptable. In the adult patient, 12 to 20 breaths should be expected. The next thing you want to assess is whether or not that breathing pattern is regular or irregular. Do you see the patient breathe at a nice, steady rate, even if it is fast, or are they taking very quick breaths and then having pauses in their breathing? These are important to note. In many normal pediatric patients, there is some variation in their respiratory pattern. However, if the patient is taking very quick breaths and then all of a sudden stops or slows way down and the breathing rate picks back up again, this can be a very ominous sign of impending respiratory failure. In addition, in a baby or a small child who is breathing too slow, that can also indicate that a child is experiencing respiratory distress and soon-to-be failure. Next thing we want to look for is if the child is experiencing any drainage from their nose, from their mouth, from their endotracheal tube. All of these things should be assessed for color, consistency, and their amount. It could be a small, moderate, copious. They could be thick, thin, white, clear. The color will often indicate the type of drainage that the patient is having. Clear drainage will often indicate normal secretions. Yellow or green secretions often indicate that the child has some sort of a bacterial infection. Next, we want to look for any signs that it's hard for your patient to breathe. We call these signs and symptoms of respiratory distress. You will often see that a child is using extra muscles or ways to get a good solid breath in. The first and most common thing that we see in children is something called nasal flaring. This is when you will see the child's nostrils actually flare out and in as they try and take their breaths. Head bobbing is something that we often see in babies. You will actually see their head bob back and forth as they try and take their breaths. This indicates extra effort in their breathing pattern. Retractions are the next thing you want to be aware of. You can see retractions in many different places, but a retraction is defined as the skin pulling in from the outer walls in toward the ribs. The location of the retractions is very important. You want to assess the child from their neck down to their thorax. You can have retractions in the upper part, the middle part, or the lower part of the chest. You will always need to classify your retractions in terms of their location and their severity. Next, you want to look at how the patient's chest rises and falls as they breathe. You should see that the patient is having equal expansion on both sides of their chest as they take a breath. One side, you may notice, is rising more than the other. This would indicate a problem and needs further investigation. In infants, it's normal to see their abdomen move and expand as they take a breath. However, if you see a sick baby breathing heavily with their abdomen pulling forward and higher and their chest dipping below, this can be known as diaphragmatic breathing and is also a concern. It is also a concern if you note this in an older child. Next, we want to look at the timing that it takes a patient to take a breath in and a breath out. We talk about this as the I to E ratio, or the inspiratory to expiratory ratio. It should take about 2 times as long for a patient to exhale their breath as it did to take it in. If it's taking longer for the patient to breathe in, this could indicate an obstruction in their upper airway. If it is taking longer to breathe out, this could mean there is an obstruction in their lower airways, and it is making it harder for them to force the air out of their lungs. In a healthy patient, there should be no extra effort at all or any change in that I to E ratio, and any increased effort should be considered abnormal. Next, we want to move on to the listening component of your exam. This is step 2. As we said before, you want to optimize your patient's position. In a baby, you don't want them crying. It will be difficult to hear their lung sounds. So if the child is comfortable in their parents' arms, make every effort to leave them there and keep them calm and comfortable so that you can get an effective exam. For the exam, you'll obviously need a stethoscope. In addition, if at all possible and the patient is not intubated, it will be best to be able to listen to their chest on both the front as well as the back. The first thing we're going to do is listen without a stethoscope. There are a few things you'll be able to listen to. First is stridor. That's known as a high-pitched noise that is heard as the patient takes their breath in. If you hear stridor, it often indicates that the patient has an obstruction somewhere in their upper airway. This could be a foreign body, or it could be swelling on their internal airway. Then you want to listen for any upper airway congestion. Do you hear noises around their nose, their throat? Are they coughing a lot? All of these things could indicate that they have stuffiness or secretions collecting in their upper airway. Next, does the child have a cough? The description of the cough is also important. Is it effective? Are they actually coughing up sputum? Or is it dry and hacking? Does the patient tell you that something makes the cough worse, maybe when they lay down or sit up? Is it barking and hoarse sounding? If the cough is producing sputum, it may be important to collect that for specimen. All of these characteristics can help the provider to diagnose the patient. Now it's time to listen with our stethoscope. The lung has a number of areas that you want to focus on, but the most important thing to remember is that you always want to compare the right side to the left side and make sure you listen to both the upper portions and the lower portions of the lungs. We talk about doing this in what we describe as a Z pattern. I'll demonstrate this now. We'll start on the right upper part. Make sure you listen to both the in and out. Next, you want to move over to the left upper. In similar fashion, you continue to move down the patient's chest, left to right, right to left, always moving down before you change sides. Again, it's important to compare the depth and the quality on each side of the patient. As you listen, you want to listen for other noises as well, not just the aeration. Do the lungs sound clear? Is the air moving in and out with a nice clear sound? Or do you hear extra audible sounds? This could indicate things like secretions. If you don't hear any aeration, this is incredibly concerning. This is why it's important to note, do you hear no aeration on either side, or is it only on the left, only on the right? Sometimes you'll hear air on the right and the left in the upper, but maybe not in the lower portions. All of this information, again, will help you to determine and troubleshoot your patient. Another sound that you should be very familiar with is the wheeze. A wheeze is a high-pitched noise that can be heard on both inspiratory and expiratory breaths. If the wheeze is heard on the inspiratory portion of the breath, it often indicates an obstruction in the upper portions of the airways. However, if you hear the expiratory wheeze on the lower portions, it can indicate that there's a lower airway obstruction. This is commonly heard in asthmatics or bronchiolitics. It is a very important note to say that if you've heard wheeze on your initial respiratory exam and that wheeze disappears, be sure that the patient has not lost their ability to aerate at all. Sometimes we're reassured by the absence of the wheeze, but in fact that may indicate that those airways have closed so much there is now no air movement at all through them. Coarse breath sounds are the noises you'll hear when the patient has secretions or fluid buildup in the lungs. This generally indicates that the patient needs to cough, or if they have an endotracheal tube, you may need to suction them. Crackles or rails are often heard in the lower portions of the lungs. This typically indicates that there is extra fluid or friction taking place in the lower portions of the lungs and is usually associated with pneumonia or pleural effusion. These sounds can all be heard on both inspiration and expiration, though may be more audible in the expiratory phase. The next thing we want to do is feel the patient. When the patient talks, you can feel something like tactile fremitus. If you place your hands on the patient's lungs and they speak, you should actually hear the vibration. These should be equal on both sides. Crepitus is something very specific and will happen if air develops under the subcutaneous tissue in the child's chest wall. You can palpate around and will often feel tiny air bubbles along their chest. This is also incredibly concerning as it can mean there is an air leak somewhere under the patient's skin. So in summary, the respiratory assessment and monitoring of your patient in the ICU will be critical. We want you to use the look, listen, and feel model to complete your comprehensive respiratory exam so that you look at your patient for any signs of distress or difficulty breathing, listen for any abnormal lung sounds, and to feel for any crepitus or secretions.